Yeah, we can see your screen.
Yeah. So, good afternoon to Deep, and thank you for giving me this opportunity to speak about JCI 8th edition implementation part snippet session. I know JCI is such a vast this thing, it's not possible for us to complete even in one day or 1 hour also. So, but I'll give you some solutions and some tips on how to go. But I know that it's a mixed group where people who have seen JCI and people who have not seen JCI, because so keeping that in mind, I will use a combination technique of both to address both people who have not seen JCI at the same time to people who have already seen JCIs to help them in the 8th edition implementation. So this was the hospital recently which I completed last month. That was one of the first few hospitals in the world to get their initial accreditation as per the 8th edition standards. Okay. So as you know, JCI has introduced two new chapters. That is one on healthcare technology and the second being on global health impact. We have about now 15 chapters in JCI, 237 standards and about 1094 measurable elements. And the chapter which has a maximum number of standards is assessment of patients. Okay, and the second being staff qualification education. Okay. So let us go one by one. So the major changes, now accreditation participation requirements are now scoreable. That's a very important thing. Okay. Because previously it used to form as a guidance document, now these things are scoreable. Two new chapters, global health impact and healthcare technology, are part of the survey. But GHI is not scoreable till 2026, but still you have the GHI interview, everything going on during the survey. Then IPSG goals, previously if any not met in IPSG goals, records will be held. So that is not there now. So not met in IPSG will not prevent a hospital from getting its accreditation, but it doesn't mean that we should neglect the IPSG goals. Don't take it in the other sense. And no partially met in scoring, it's only met or not met. So coming to the accreditation rules, the organization demonstrate acceptable compliance with each standard. It should be 5, okay, for each standard. Then the organization demonstrate acceptable compliance of at least 8.5 for each chapter. Then it demonstrate an overall acceptable compliance 9 out of 10 on all the standards to get the accreditation. The denial of accreditation, one or more standards is scored less than 5. The aggregate score of one or more chapter is less than 8.5. And the aggregate score for all standards is less than 9. So new requirements, IPSG goal. As you all know, IPSG goal 6 on prevention of falls has been moved to AOP2 as a separate standard. Hence, we have only 5 IPSG goals now. IPSG2 monitoring of critical cell stat action taken based on same as and tracking the deviations is one of the new measurable elements which has been introduced. Though we predominantly follow all these things, it is not something which are learning new or something, but it has been put as a separate measurable element recently. IPSG goal on high-risk medication storage of concentrated electrolytes are not limited to critical areas and crash cart alone. The same can be stored in other areas, however, with the proper rationale. You need to mention the proper rationale if you are storing concentrated electrolytes other than the critical areas. Then a proactive risk assessment for the use of concentrated electrolytes across each areas of the hospital. When I mean to say each area of the hospital, where and all you are showing the concentrated electrolytes needs to have a separate proactive risk assessment. We tend to do a proactive risk assessment across the hospital. That is not enough. Let me reiterate that. Okay, that is not enough. We need to do a proactive risk assessment for each area where concentrated electrolytes are being stored. Okay. Then strategies to prevent harm from highlight medication to be based on risk profile. Example, storing neuromuscular blocking agents from other highlight medication, the warning level, especially when you're storing them in a fridge, and chemo drugs, okay, like writing risk of extravasation. So those kind of things needs to be there, okay, when you're storing with other highlight medication. Then revisiting the list of highlight medication on an annual basis and during the addition of new drugs to the formulary. This has to be done at least once in a year. Safety of plasma drugs, separate standard new requirements like mentioning medication's purpose on prescription, minimum number of letters that needs to be typed while ordering, see computerized physician order entry with the doctors. Okay, for example, dopamine, you have to type at least 5 letters for the drug to get displayed. Okay, just to prevent any errors. Then IPSG4, very, very important. you need to perform another timeout if you're going to do another procedure for the same patient and same operating time. For example, a patient with a road traffic accident. Okay, the neurosurgeon does a craniotomy. So at the end of the craniotomy, then the maxillofacial surgeon comes to do something on the jaws. Okay, reduction of jaws, whatever this thing. So then a separate timeout needs to be done for that. Okay, so this is a new requirement. Then coming to the chapters, let us see the first chapter, access to care and continuity of care. So it mainly talks about screening for admission to the hospital, admission to the organization, continuity of care and reducing barriers of care. This part I'm just reading it for the benefit of those who are new to JCI. Then discharge, referral, follow-up, discharge planning done at the time of admission, transfer of patient, then it talks about transportation, observation beds, and what are the screening and diagnostic tests before admission. So more emphasis was given to the screening for communicable diseases. This we faced in the recent survey also. Screening for communicable diseases at all points of entry to the hospital, namely the ER, OPD, IPD, and the patients who are transferred from other hospital and during medical transportation. That needs to be, you need to prepare a checklist for it. Okay, some guidance is given in PCA 7 on how to make a checklist for that, where you will also include the travel history of the patient. Then minimize financial barriers for patients by identifying sources of funding. This we used to do in our hospital. Wherever there's a challenge, we used to have some tie with the trust. But now this has been included in the standards itself. Okay, like the hospital having some tie-up with some trust. Okay, crowdfunding. So those kind of things. Then medication reconciliation, very important part. Though we have been talking about it, but still we tend to do it at the time of admission. But during all transitions of care, medication reconciliation is important. Okay, and that needs to be incorporated along with the transfer summary itself. Then leaving against medical advice, LAMA analysis by the hospital for identification and reasons for any corrective actions. Okay, and for doing any opportunities for improvement. Then hospital can restrain a patient. This is another new requirement. Hospital can restrain a patient from LAMA if the patient can be threat of self-harm or harming others. Very, very important. Okay, the hospital can restrain a patient from LAMA if the patient can be, for example, a patient with communicable disease. If the risk of the patient being a threat to the society, definitely the hospital, in concerns with the laws of the land, can restrain the patient from going on LAMA. Then coming to the next chapter, assessment of patient. It mainly talks about, I think, is it okay now?
I think there's an echo.
Just give me a minute.
Hi everyone, we'll be taking your questions later. I think somebody has skipped two devices. I request all of you to mute.
Hello? Yeah. Yeah, okay.
Hi, can I request all of you to keep yourself muted for the time being? We'll have a question answer later on. Dr. Abel, you can join in.
Yes. Okay. Yeah, can you hear me now?
Yeah.
Sorry for the interruption. So the areas of focus regards to AOP chapters, assessment of patient. It talks about the lab services, blood bank and transfusion services, radiology and diagnostic imaging services. So when coming to assessment of patient, the patient's physical, psychological, social status, economic status, spiritual, cultural assessment and health history is documented. Okay, but you can divide who will do what. Okay. So for example, history and physical is done by the doctors and some by the nurse. Economic history spiritual cultural assessment can be done by the nurses. Like that, the hospital can have its own policy, who will do what. And there needs to be a difference between screening of pain and assessment for pain. Not only pain, even for nutrition, falls, and other things also. We need to differentiate between what is screening and what is assessment. For example, just screening for pain. You have pain or not. That is screening for pain. Okay, and based on that, if the patient has a pain, then you go for a detailed assessment. This is one thing the surveys also want us to differentiate in this thing, because many times we get confused between assessment and pain. This is one of the pitfalls we need to avoid. Then the minimum content of assessments for outpatient, ER, and inpatient needs to be documented in the policy. Very, very important. Okay, who will do what? Okay, so that needs to be documented along the time frame for completion of the assessments. These need to be put in the assessment of patient policy. Qualified person only for assessment, table degrees as to who will do what. Assessment of special population, very, very important. History and physical, revisit or validate for patient. Again, this is against old standard, but still I'm reiterating for the benefit of others. Okay. Then this is the new requirement where they mentioned the nursing IPD assessment to be completed within 8 hours and doctors within 24 hours. This is a new requirement. So maximum within 8 hours, the nursing IPD assessment has to be completed. So blood bank, a qualified individual, it talks about their qualifications and their training. Then it talks about the donor selection, screening, collection, storage, compatibility testing and distribution. Monitoring of use of blood and blood products and availability. And more important, 8th edition talks about more about the hemovigilance program by hospital covering the entire blood transfusion process and report any adverse events. Some countries have the hemovigilance program centrally, where the government, when the Ministry of Health itself has a separate program where all the hospitals needs to register the program. Then process improvements and optimal use of blood and blood products, ensuring optimal patient outcomes and maintenance supply. One can be doing a audit on cross-band transfusion ratio. That could be a good start. Then corrective action based on any adverse event or near miss, focusing on the prevention. Then this is a new standard of nuclear medicine, AOP6. When applicable, the hospital establishes and implements a nuclear medicine and safety program that complies with the laws and regulations. Qualified individual, okay, a nuclear medicine specialist, implementation of radiation safety protocol to use as low radiation as possible. And one more thing, they give the requirements with regards to the hot lab, which we use in the nuclear medicine department with environmental controls, room air to be negatively pressurized and exhausted with no air recirculation, and environmental radiation surveillance. We'll be talking about this later also. So then we go to the third chapter, which talks about anesthesia and surgical services, where you have the organization management of sedation anesthesia services. Then it talks about the sedation care, anesthesia care, and surgical care. So surgical care that involves medical devices planned with special consideration of process and procedures. So there is a process for tracing of implantable medical devices. This we already know, we have been doing it. And one important thing where they mentioned the 8th edition standard is duration of support for tracking of the implantable devices. How long the hospital tracks it needs to be conveyed to the patient. Okay, and we need to have a policy also for that. This was also verified during the assessment. Process for noting in case of problem with the device, very, very important. And what are the extra precautions you will take. Then care of patients. It talks about uniform care delivery for all patients, care of high-risk patients, recognition of changes to patient condition, resuscitation services, food and nutrition therapy. It talks about pain management. It talks about end-of-life care, organ and tissue transplant services. Then it talks about transplant program using living donor organs. So when we say uniform delivery of patient, access to care and treatment does not depend upon the patient's ability to pay. This we saw in ACC also, where there's a separate requirement where the hospital needs to make some arrangements for funding for the patients wherever possible. Okay, care is always available 24% by qualified practitioners. The level of care provided is same throughout the hospital, doctors and nurses, irrespective of the ability to pay. Then care coordination, individual plan of care based on initial assessment and reassessment. The uniform process for prescribing medication orders. One more important thing, with most of the time what happens is medication orders has to be returned, though it's an old standard which is there from 4th to 6th edition, wherever it is. Okay, in all the standards this has been there, but unfortunately what happens many times we write the progress notes and again we write the drug chart also. So uniform, to avoid errors, we are supposed to document the drugs, okay, prescribing the drugs only in the uniform location. If text message is done the same to be encrypted and secured. Then recognition of changes to patient's condition, like monitoring of early warning signs, identification of patients who deteriorate and who can go for a cardiopulmonary arrest, Training to staff on recognition of early warning signs and taking appropriate action based on the same. Staff to seek additional assistance from trained individuals to improve clinical outcomes. One suggestion here is when the early warning signs score, what we can do is from 1 to 4. Okay, we can always request the duty medical officer on the floor and the nurse in charge to take care of the patient. And many hospitals, two things we have. One is the CPR team and second is the RRT team. So the thing is that if the score goes beyond 4, then you can call the RRT team. Okay, so these sort of things are the new requirements, interpretation of the standards. The resuscitation services will be made available 24/7, 365 days. Training of staff in ACLS and BLS immediate and ACLS within 5 minutes to be made available is mentioned in the standards also now, but it can be less than 5 minutes also. Modules are connected for resuscitation services, adult and pediatric separately. Internal review process for all resuscitative events and identify opportunities for improvement. So what and all needs to be part of the internal review process, okay, has been clearly defined in the standards now. Frequency of early warning signs prior to deterioration, this is one of the parameters which needs to be part of the review process. Then you have the timeliness of staff response to cardiac arrest. Then you have the timeliness of ACLS team arrival, then quality of the CPR and outcomes following cardiac arrest. So all these points needs to be part of the internal review process. So then one more thing, important thing is the risk for suicide. So we need to have a valid screening tool for the risk of suicide. Okay. So one can be the PHQ tool, but again, each hospital can have their own this thing. There is no, prescriptive this thing for that. So when the patient with suicidal ideation, plan, intent, or self-harm behavior disparities are identified, training and competency assessment for the staff handling such patients, very important. It should be made part of your privileges also. Then guidelines, how frequently you will reassess a patient with the risk of suicide. That is again very, very important. So you need to, depending upon the assessment, you need to define how frequently you will reassess the patient. The frequency of monitoring a patient, high risk especially. It can be every day, it can be once in 3 days, so the doctor takes a call on that. Protocol for counseling and follow-up care at the time of discharge of patient with risk of suicide. So this also need to be made part of the discharge planning. When the patient gets discharged, counseling needs to be given to them. The new requirement for transplant, the hospital complies with the organ, tissue and cell transplant responsibilities. The intent is utilization handling to avoid waste or loss of this critical resource. Compliance to laws and regulations including data sharing when required. Protocol for acquisition, receipt, storage and issuance of organs, tissues or cells. Verification of organs at the time of receipt of organ, that package integrity is met and temperature requirements were controlled and acceptable for the organ. So you need to make a checklist for this, okay, when you receive the organ, okay, and you need to document these things in the checklist, what temperature was there. The hospital follows the tissue supplies or manifests written directions for transporting, handling, storing and acquisition. Receipt, storage and issuance of organs, tracking of transported tissues. Refrigerated freezers, nitrogen tanks and other storage equipment used to store organs, tissues and cells at a controlled temperature have functional alarms. This functional alarm is very, very important, and an emergency plan, okay, for that same. Then coming to the next chapter, international patient safety goals. As I've already told you about it. Just for the sake of continuity, I mentioned one more time. Let me reiterate that. So identification of patients, improve effective communication, process for reporting critical results of diagnostic test, standardized process for handing over communication, doctors, nurses, and hospital staff to patient at the time of discharge, very important. Improve the safety of highlight medications, new requirements for neuromuscular blocking agents, chemo drugs, etc. Safety of sound-alike and look-alike medication, safe use of concentrated lights, and more important, you do a proactive risk assessment where they are stored. Ensure safe surgery procedure, pre-operative verification, site marking, timeout and sign out. So difficult error and aspiration risk also forms a part of it. Another timeout if new procedure is initiated, and blood loss more than 5 ml in adults and more than 7 ml per kg needs to be documented. Reduce the risk of healthcare associated infection. Mainly talks about hand hygiene. So next chapter is medication management and use. So the areas of focus will be organization management and medications across hospital. It talks about antibiotic stewardship, selection and procurement of medicines, storage of medications, ordering and transcription of medicines, preparing and dispensing of medicines, administration of medicines, Monitoring after medication administration. Nuclear medicine standards comes here also, it's new. We'll read about it. Then administration monitoring, privileging process for medication, especially high-risk medication prescription methods. For example, chemo drugs, we give them privilege only for the medical oncologist. And for some of the anticoagulants, like heparin, okay, you give them privilege. Not the duty medical officer will not be in a position to change the dose for heparin. It is only minimum by MD general medicine. Like that, we give them the privileging process. Again, it depends upon the hospital policy. Okay, preferably privilege to these high-risk medications is based on the training which the doctor undergoes. Okay, and the qualifications. Verification of prescription order, time, frequency, dosage, route, and identity of the patient before administration has to be done. Protocols for self-administration of medication, again it depends upon the hospital policy. Again, some hospitals will allow self-administration, some hospitals will not allow, and if the hospital allows, then there should be a proper process for that in order to minimize errors that can lead to patient safety issues. Then medication effects on patients are monitored, including adverse reactions and reported. Protocol for reporting and acting on medication errors and near misses. Then MMU, written process to prepare and dispense radiopharmaceutical in accordance with the laws and regulations and clinical practice guidelines. Radiopharmaceutical prepared by under the supervision of appropriate trained and qualified individual, preferably a nuclear medicine doctor, a nuclear technologist, okay, a registered pharmacist. Sterile radiopharmaceutical facilities are designed and controlled to minimize airborne. We saw these requirements previously in the previous slides. And provide an opportunity of lighter and comfortable working environment. Radiopharmaceuticals are transported and stored in accordance with the laws and regulation guidelines to maintain stability. Very, very important. So before the half-life gets over, that needs to be transported and given to the patients. Radiopharmaceuticals are packaged in appropriate containers and labeled to provide. So these essential things which need to be made to be part of the package include the name of the radiopharmaceutical, dosage, expiration date, and the radiation warning symbol. Then radiopharmaceutical dose is verified as within 20% of the prescribed dose. This is very, very important. This is as per the nuclear medicine guidelines. Okay. If you read the Journal of Nuclear Medicine Technology, you will find all these details also. Okay. So the dose is verified as within 20% of the prescribed dose, and process to determine competency for family or others administering patients medication in the hospital. Again, it depends upon the hospital policy. Okay. Written process addressing prescriber notification of adverse events and adverse reactions. Hospital conducts a root cause analysis when data shows adverse event patterns and adverse event trends. Okay. So this is an example of nuclear medicine prescription where you have the patient's name, patient ID, okay, radioiodine, whatever you can select, okay, decide procedure, okay, prescribed dosage, signature of the authorized user, patient spell name. Since it's a new slide, I thought I'll probably give you an example of this. Technology signature, and if the patient is pregnant, okay, then or not, what are the precautions you will take, dose dispensing radiopharmaceutical, then prescribed dosage, dose and caliber assay time, verify assay dosage is within 20% of prescribed dose, return revision to the return directive was needed. If yes, return revision must be completed prior to administration. Okay, so this is just an example to help you understand. Then we go to the 7th chapter, patient-centered care, which talks about the identify, protect, and patient rights. Inform the patients of the rights. Include patients' family in decision when appropriate decisions about patient's care. It most talks about the informed consent, very, very important. Education of staff about patient rights, organ and tissue donation. So identification of vulnerable population by hospital leadership. Okay, so defines vulnerable population based on the predetermined factors. Okay, for example, an adult risk assessment which is based on the laws and regulations and different population needs to be done. For example, what is given in the book I've just copied here, people with disabilities, chronically ill, but this list can be exhaustive. Some can be added, some can be taken off also. Socio-economic disadvantage, elderly, frail, children and adolescents, racial and ethnic minorities, subpopulation of that, refugees, prisoners, state-led persons, indigenous people, women, people living with HIV/AIDS, written policy and a process for risk management for each identified problem. For example, patient with disabilities, what are the risk factors, okay? And with regards to risk management, whether the hospital has a proper, say, grab bars, okay? Proper wheelchairs are there, okay? And so those kind of things needs to be there. Then disclosure of clinical, again, this is a very, very important chapter, okay? And a very sensitive thing also, which has been defined in PCC 02.03. What is the definition of clinical error done by the hospital? Protocol for disclosure of clinical errors. Okay, not all errors need to be defined, need to be told to this. Okay, on what circumstances clinical error is disclosed, who will disclose the clinical error to the patient, process to analyze clinical errors and prevent the recurrence. Hospital will define situation during which clinical errors will be disclosed, not required to disclose all the clinical errors. Okay, so you make a list. First, you define the protocol. Who will disclose the clinical error? Preferably, it is ideally by the doctor only. Okay, under what circumstances? For example, there was always a confusion between complications and this. For example, if I'm going to do an ERCP, and suppose if I'm going to get a say a duodenal perforation, that I'm writing it as part of a risk in the consent itself. Those kind of things needs to be disclosed. But suppose if it's going to be a patient is allergic to beta blockers, and I am giving a beta blocker to the patient inadvertently, that error needs to be disclosed. Okay, so on what way it has to be done is left to the hospital. Okay, then we go to the next chapter, facility management and safety. So it talks about leadership and planning, safety, security, hazardous materials, fire safety, medical equipment, utility systems. It talks about the emergency management, construction, renovation, staff education. Then when we talk about safety and security, program for ensuring safe physical facility protection from personal harm and damage to property. How frequently the facility is inspected, there needs to be a calendar for that. All staff of the hospital are identified, separate identification methods for vendors, contract workers, and volunteers to be in place. Very, very important. Okay, you can give them a badge, okay, and you can give them the visitor ID, whatever it is. Again, it depends upon hospital policy, what they need to choose. Identify areas for it, because these things, more than protocol, they will be verified on ground by the surveys during the JCA survey. Okay, for example, if a JCA survey is going on and suddenly you find a vendor who's working on say fire equipment, they will check whether the vendor has a proper identification, okay, proper restricted fire restricted signages are there, okay, at the place of work, and if a fire watch is there, okay, due to positive time, I don't have time to explain all these things in detail, but just a gist of it. Then proactive risk assessment of areas prone for potential injury, and this is an important requirement which has been included in the 8th edition standard, annual assessment of workplace conditions to prevent workplace violence. Okay, so one simple thing could be the list of incidents related to patients and staff to staff, okay, grievance, okay, so these kind of things can be taken into account. Then active surveillance of all areas, doing pre-construction risk assessment and planning for demolition, construction and renovation. Then fire safety, we have protocol for prevention, early detection, suppression, abatement, and safe exit response to fire and non-fire emergencies. Mock drills for fire and smoke safety, including devices for early detection of fire at least once in a year. And please remember, all the 8 FMS plants need to be trained, not only the non-clinical staff, doctors, nurses, everybody needs to be trained on this facility plans. But it need not be a detailed one, but at least what is the plan, okay, how to implement the plan, and one or two monitoring indicators needs to be told to the team. Okay, so when we talk about fire risk assessment, it talks about pressure relationship in operator rooms, fire separation, smoke compartmentalization, fire exits, kitchen grease producing cooking devices, okay, which can be which are prone for fire, laundry and trash chutes, emergency to prevent fire from spreading to other areas, emergency power systems and equipment, medical gas and vacuum systems. Then we go to the next chapter, governance, leadership and direction. Okay, so he talks about the governance of the hospital and the organogram. The organogram needs to be very clear. Okay, you cannot make an organogram just for the sake of showing to the auditors your structure of authority, accountability, everything needs to be very, very clear. Then it talks about the chief executive, the head of the organization accountabilities, hospital leadership accountability. Then it talks about hospital leadership for quality and patient safety. Then it talks about hospital leadership for contracts. Okay, then hospital leadership for resource decisions. When I say contracts, you mentioned the parameters that needs to be taken into account while reviewing the contract also. Then it talks about supply chain management, identifying items which are at most risk. Then it talks about clinical staff organization accountability, including selection of clinical pathways, clinical practice guidelines. We need to select at least 5 clinical pathways and guidelines. Direction of each hospital department and services. Then it talks about the departmental quality indicators used in performance evaluation. Talks about organization and clinical ethics. Okay. Then most importantly, again and again, this thing will come again in SQE also. Okay, we saw another place also. So workplace violence prevention is very, very important. We need to give a lot of importance to that. Then written policies for uniform care, written definition of central events and process for supporting staff involved. Okay, your central event definition needs to be clear, very clear within how many days this RCA will be completed. Data collection assessment intervention for diagnostic errors. Okay, workplace violence prevention, focus on workplace prevention program. Focus on staff education for recognition and prevention. Again, in FMS also in security, we saw about it. Okay. Then during the survey process, review of the organization workplace violence prevention program, review of documentation of staff education, interview staff about the workplace violence prevention program and how they would handle situations. You can have a protocol, you can have a separate code also for that, again, depending upon the policy of the hospital. Okay. Then potential patient traces for a patient requiring de-escalation. Then we come to the 10th chapter that talks about healthcare technology, where we talk about information technology in healthcare, then management of lasers, electrosurgical and other optical radiation devices. Okay, laser was already there previously, this thing also it's not new to us. And this chapter on information technology has been carved out from the MOA. Okay, we used to have all these requirements in the management of information, but now this has been carved out and put as a separate chapter. Okay, so information technology in healthcare, it talks about a qualified individual to oversee hospitals' health information technology and process. It talks about the process and criteria for selection and testing of health technology, ensuring quality of patient care compliance with local laws and regulation, security and confidentiality of the patient. It talks about the guidance for providing telehealth services, okay, and some of the countries have their own national guidelines which needs to be followed. Process for selection of AI clinical decision support tools, response to planned and unplanned downtime of data systems, response to cyber security risk and management of lasers, electrosurgical and other optical radiation devices, and it also talks about your radiation safety officer for lasers, for optical radiation. Okay, ionizing radiation different and optical radiation is different. So telehealth services written guidelines to secure patient information, maintain confidentiality. Okay, patient privacy and confidentiality needs to be given utmost importance during health technical services. Process to ensure integration of information across platform interfacing. Then staff training on information security and cyber security threats such as phishing. Okay, writing, for example, sometimes you might really get a phishing mail, and sometimes proactively the IT department can take a small session on how to prevent phishing this thing. Okay, then must have written guidelines and process for oversight of the effectiveness of AI tools, approval and implementation process. Human factors involvement in final decision making, that is a very important. Whatever AI tools we select, finally the human factors involvement in final decision making for patient care. It then security and privacy of patient data when we select a AI tool, this needs to be taken into account. Identification of system discrepancies, analysis from providers and relevant third-party sources, updates to software technology as deemed appropriate, then ethical consideration needs to be taken into account. Selection of AI tools by qualified individuals, tracking, trending, and reporting of usage of outcomes to stakeholders. See, this needs proper care needs to be taken when choosing a AI tool. For example, sometime back, a year back, when I went to one of medical exhibition, okay, there they said by looking at your scan, they had a mobile app that will scan your body and all your vitals, everything will be displayed. Okay, and they were telling, and suddenly one person came and his HbA1c was shown as 5.4. But ultimately, just before coming to the exhibition, he had a written report which says his HbA1c was 9. Okay, so there needs to be a proper, what to say, thing with regards to selection of the proper AI tools. Proper precautions needs to be taken. Do a proper peer review and see which hospitals they are doing. Okay, that has to be done. Then examples of AI in healthcare, sepsis triggers, wound management, medication reconciliation, medication dosing, diagnostic code selection, aid in rapid response procedures, creation of treatment guidelines for urgent condition, and interpretation of lab and testing results. Okay. Then cyber security and cyber risk management. You also need to do a mock drill for this. Okay. That for example, if there's a cyber security risk or cyber security attack on the hospital HIS system or information technology system, what will be done? A, B, C has to be written. You need to have a written protocol for that. Okay, and how does the manual thing take place? And once the things are set right, how the things are reconciled again into IT system. So you need to, like how we used to do for a disaster management, similar thing you need to do for a cyber security, cyber risk management drill also. Then he talks about internal external communication strategies, recovery tactics, and ongoing backup process, ensuring data integrity, confidentiality, and security. Then we go to the 11th chapter, it talks about management of information. So areas of focus will be information management, management and implementation of documents, medical records, information technology in healthcare. Okay. So the hospital maintains the confidentiality, security, privacy, and integrity of data and information to process and protect against loss, theft, damage, destruction, ransomware, and other cyber attacks. Conducting and documenting ongoing information risk assessment and at least annually. Okay, you can use a tool for it. A lot of tools are available. Prevent data breaches for login behaviors. For example, if a person is unable to log in for more than 3 times, there should be auto lock system. Then malware training, email phishing reporting, how does to be done? Okay, and for example, you can get some tips can be given by the IT department. Okay, usually when the person who's sending a phishing email, they'll use the same language. Okay, they'll use the same language how the recipient receives. Okay, for example, if an XYZ CEO is there, they will send a mail as though it's coming from the CEO. But if you open and see, there will be some other email ID. Okay, and initially while seeing the mail, we just get panic and try to reply to we should not do. Okay, so then data and information are stored in a manner that protects against loss, theft, damage, destruction, ransomware, and cyber attacks. The hospital establishes a return policy with procedures to follow in the event of successful cyber security attacks. You need to have a proper business continuity plan also. So clinical staff, decision makers, other staff members are educated and trained on information system, information security and the principles of information use and management. Staff should receive cyber security training related to job description, training including password protection, how to choose a password. You cannot choose a password which is easily recognizable. This happens in bank also, right? Okay. Even when the bank prompts us to change the password, it gives us some guidelines on what kind of password is supposed to. Similar thing here also. Then training may include topics on how to deal with malware and ransomware, email phishing, device management. For example, how long can you keep a device open? Okay. For example, if a screen is open for more than 2 minutes, there should be an auto lock system. Safeguards for sensitive information, device updates, how the updates take place, suspicious activity reporting. Okay, staff receive education ongoing. You can make a training module for the IT team can make a training module for this, and the same can be decimated. Staff receive education ongoing annual training related to cyber security based on the roles and responsibilities. Then we come to the 12th chapter. It talks about prevention and control of infection. It talks about planning and testing and implementation of quality and patient safety. Data to demonstrate that improvements are effective and sustained. Documentation of successful improvements. Risk management program involving identification, prioritization, reporting management, and analysis. There needs to be a proper risk management program depending upon the existing controls available in the hospital. Okay, so one product risk reduction exercise conducted every year. Redesign a high risk process based on analysis of test results. Then, when coming to medical equipment, devices, and supplies, it talks about how to reduce the risk of infection with medical surgical equipments, cleaning, disinfection or sterilization or improper use or storage of equipment, low and high level disinfection, protocol for managing reuse of single use devices, including the number of times. Okay, and you need to do a proactive evaluation of safety of reusing single use items. Very, very important. You can do an FME on that based on the existing controls which are there for your hospital. Cleaning process for each device is followed as per protocol. And most important is final point, tracking wherever SUDs are used, tracking of SUDs against each patient. Again, this protocol, this part is left to each hospital's policy, how they will do it. Okay, but whenever SUDs are being reused, one is the number of times, and second is we need to give them an ID, different ID we each use, and the same needs to be documented in the patient record also for retrospective tracing. Okay, so it's very, very important. This was completely checked. And one more important thing you do is about integrity check. Before using an SUD, you do a proper integrity check. Like for example, if it says guide wire is any kinking, okay, if there any stain, those kind of things needs to be taken into account. Then 13th chapter talks about quality improvement and patient safety, where it talks about area of focus will be management of quality and patient safety activities, clinical pathways and clinical practice guidelines. It talks about quality improvement initiatives on cost and efficiency. It talks about incident reporting and sentinel events, quality measure selection and data collection, analysis and validation of measurement data, gaining and sustaining improvement and risk management. So new measurable element, the hospital implements measures designed to encourage patient safety incident reporting by hospital staff. See, one way you can do is You can incentivize them. You can send a email blast to all your employees saying that whichever employee reports the maximum number of incidents particular time will give an award to encourage incident reporting. Surveys will validate that hospitals have measures in place designed to improve patient safety in incident reporting. This may be part of the overall safety culture improvement efforts. Hospital will not be required to show evidence of improvement in incident report, but should be able to speak to efforts, encourage. How do they encourage reporting? This will be part of your safety culture program also, AHRQ survey. Okay. Then it talks about the new requirement defining quality leaders and staff qualification. Okay, so it can be any quality qualification in healthcare. Okay, it need not be CPHQ alone. This we clarified it also. Okay, it not be only not only CPHQ, it can be anything, any quality qualification from a recognized institution that will do for it. The new requirement to define qualifications of risk management personnel. Okay, for example, what are the certifications he or she has undergone to be qualified as a risk management officer? Anything from a recognized institute should suffice. Then 14th chapter talks about staff qualification education. It talks about the manpower planning. It talks about the determining medical staff membership. Then it talks about the medical staff clinical privilege. Then it talks about the ongoing monitoring and evaluation of medical staff members. Focused practice evaluation is a new standard. Okay. Then it talks again workplace violence comes. Okay, so workplace violence we saw in 4 chapters till now. Then it talks about the medical staff re-employment and renewal of clinical privileges, nursing staff, other healthcare practitioners. So staff evaluation should be based on job responsibilities, and evaluations are performed by staff with relevant training and background. Okay, so whenever a review is being done, it has to be done by a person who's thorough the subject or who knows about the subject. Then he or she in a position to evaluate the staff under him. Recurring stresses compounded by ethical decisions that clinical staff contend with that often create conflict with moral ethical values are played a pivotal role in deterioration of mental health. So now includes SQE2, now includes mental health monitoring evaluation of staff also. Okay, again that can be an escalation matrix. For example, immediately there's an issue, they can report to the immediate manager, and then if more help is needed, they can probably refer the person to a clinical psychologist or a psychiatrist. Okay, and again a hospital can probably define a policy. There is no one best way of doing things. Each hospital is free to have their own policy for this. Then it talks about the provision of resources for the same, and action takes under decline. So workplace violence, it's initially ongoing based on roles and responsibilities. It talks about education and training must include define what constitute workplace violence. It can be between patient to staff, it can be staff to patient, and it can be patient to patient, it can be staff to staff also. Okay, patient to patient may not come, but definitely staff to staff. There will be instances where 2 staff are fighting. Okay, so these things are will constitute a workplace violence. Okay, so roles and responsibilities. So that is why you need to do an annual risk assessment on vulnerable areas. Okay, where these things are possible, which is found in FMS also. Early detection, de-escalation, non-physical intervention, and physical intervention techniques in response to emergency incidents. So reporting process for workplace violence incidents. So you can choose to have a code for this, but again left to the hospital. Okay, so the hospital defines what is the workplace violence and how do they manage it. Okay, so that needs to be very clear. Then medical staff privileges and performance evaluation, new requirements for temporary privileges granted only for a specific patient care need and for a maximum of 120 days. For example, suddenly you find that you need a vascular surgeon, whereas you don't have vascular surgeon, you get the vascular surgeon from other hospital. Okay, you need to give them a temporary privileges. Okay, after doing the proper credential check. Okay, nowadays online database are available, and that if you are giving temporary privileges, that cannot be for more than 120 days. This has to be defined in the policy or medical staff bylaws. Then most important thing will be the focused professional practice evaluation. When I say always part of granting initial privileges, 2 things. One is suppose if a doctor A requests privileges for say EP, he's a cardiologist and he requests privilege for EP also. Okay, in addition to interventional cardiology. So what happens is the person who gives them privileges, they would like to see how this performs, or at least they might give him a separate set of metrics, and then they would like to observe him for a period of say 90 days, 120 days, and then give him permanent privileges. Then return criteria to identify and address performance issues. Again, second part of it is suppose if a doctor, okay, if you find that he's a cardiac surgeon, okay, and total his mortality rates are very high. Okay, so then you put him under focus professional practice evaluation. Okay, you can observe him for a period of say 3 months to 90 days to 180 days and see how he's performing and then take a call whether to take off his privileges or continue with the privileges. So criteria are specific to areas of practice. Okay, the criteria which we define for focused professional practice evaluation is specific to areas of practice. Then assignment of clinical privileges and evaluation, evidence-based practice to authorize medical staff members to admit and treat patients. Process to include certificates, sending records, reference letters from hospitals and additional privileges may include ongoing evaluation in the department. All these things needs to be taken account in doing a proper privileging process. Working in high-risk areas, handling high-end equipment to be strictly on basis of training. Privileging is known to the concerned staff of all areas. Very, very important. Sometimes we think that privileges is only for the HR department. Privilege, a copy of the privileges can be electronic form, it can be in physical form. Okay, it needs to be kept in all the areas where the concerned doctor or a person does the procedure or operates. Okay, and admitting privileges, even the front office staff needs to know. The admission desk also needs to know which all doctor and visiting consultants have the admitting privilege. So they also needs to know about it. Evaluation of staff based on SQ1, hospital and department-wise clinical measures. Same protocol applies for nursing and other healthcare staff like EMTs, nurse practice, surgical assistant also. Temporary privileges again not to exceed 120 days. Ongoing professional practice evaluation, we already know about. We have 9 parameters given in the JCI 8th guidebook. Okay. Please, when you are designing a OPP tool, please ensure all the 9 points are included in that. Okay. Even if you take off 1 point also, you can be in trouble. Okay. Please include all the 8 to 9 points are given in the 8th guidebook with regards to making a tool for ongoing professional practice evaluation. And peer review is very, very important with regards to it, which is one of the criteria for that. And coming to the last chapter, global health impact, which is not scorable, but which is still part of the survey because it's been included till 2026. It will not be scored. So you have 5 things in this. It talks about the governance, tracking and reporting, employee engagement and empowerment, use of environmental resources, green operations and process, then procurement and supply chain, and it talks about infrastructure and service resilience. So survey process, there is a sustainability program leader, what is the scope for individual responsibilities and day-to-day function. So it's again left to the hospital to fix the qualification for a chief sustainability officer. How do hospitals engage staff with organized environmental sustainability initiatives? Okay, very, very important. What types of training are provided to multidisciplinary staff on climate change, environmental sustainability, low carbon resilient care? You can make a PPT for this. Lot of resources available online. Okay, you can choose one and that can be made part of the induction module also. Okay, how does the organization optimize water conservation, water reporting mechanisms available to organization leaders on the amount of water conserved? Water conservation is very important. What is the vetting process for new suppliers and vendors to ensure that they have sustainability and carbon emission reduction objectives in the place? So as part of your vendor rating, this part also can be one of the criteria. Okay, you can choose vendors who have all the sustainability and carbon emission reduction objectives in there as part of their vision and mission. How does the organization adapt its plan to mitigate current and future climate-related hazards and risks? Then when it comes to governance tracking and reporting, it talks about the inclusion of environmental sustainability and low carbon and resilient care hospital board agenda. See, we give a governing.
Abel, your mic is muted.
Is it okay now?
Yeah, thank you.
Yeah. So when it talks about governance tracking and reporting, so including some parts, some metrics in the board agenda. Okay, progress on environmental strategies to be included in the organization annual report. Okay, a qualified person to be appointed chief sustainability officer to ensure environmental strategy. I know it's not so easy to get the same qualifications, but it's again left to the hospital policy. One of the examples which I can suggest you is you can have one of your ESG officer. Your ESG officer, if you have one in your hospital, they say they can be given an additional role as a chief sustainability officer also. Then it talks about employee engagement and empowerment. So before going into employee engagement and empowerment, first the employee needs to know about what are the sustainability initiatives. So you can have an induction module, okay, for this thing, and the same can be part of your hospital induction module at the time of joining. So engagement and training to all employees on climate change and health across the organization. Transition to low carbon, resilient and sustainable healthcare. Alternatives to anesthetic gases with high carbon emission, sevoflurane, desiflurane, all those things you all know about it. But again, it's very easy to say, but it's again each hospital is called to take what it is based on this thing. Then it talks about green training, using green initiatives. Then use environmental resources, green operations and process. Hospital plans to reduce use of materials and environmental resources, including water emissions. Examples: on-site fuel combustion, boilers, furnaces, and vehicles. Okay, waste disposal, use of electricity. See, you suppose if the hospital camp is a very big one, you can use battery vehicles. Okay, steam heating and cooling generated elsewhere. Then procurement and supply chain, as we already discussed, you can choose vendors who have environmental sustainability as part of the board this thing as part of the vision and mission. Identification of efforts through audits and assessments. Avoid carbon products, pharmaceuticals, disinfection, medical devices, hospital equipments, and instruments which have carbon. It's only avoidance. Then infrastructure and service resilience. It talks about assessment of environmental risk and scenarios that may affect service delivery, hospital operations, and patient population. Again, climate crisis is the greatest threat to human health, causes disruptive climate events which can lead to sudden increased demand for health services. Damages to infrastructure and facilities of the hospital, power cuts and disruption of supply chain. Okay, and one way to present it, you can have a PowerPoint. See, based on the 5 things what we saw with regards to GHI, you can use a PowerPoint. Okay, you can have the standards and what action your hospital has taken with regards to that. For example, reducing carbon and more on green initiatives. Okay, and energy consumption, what your hospital has taken. So those kind of things, I can just showing you some few examples. Okay, transport department initiatives adopted from Bharat stage norms. Like in India, we have that. CNG only procurement to further reduce emissions, employee vehicle emission checks at all points. Okay, employee pickup and drop to reduce individual carbon footprints and increase sustainability commuting. Okay, then hospitals identified criteria, process and protocols for the selection of cleaning products, mops and including use of non-hazardous cleaning agents, biodegradable chemicals, eco-friendly pest control chemicals, odorless chemicals, chemicals approved with the Central Insecticide Board. Chemicals used will have approved by a serial number. Snap trap approved as per the Animal Welfare Board. So all these things can be taken into account while making your protocol. Okay, and my suggestion is just take 3 or 4 indicators at minimum to start with, and slowly see how it works for the next 6 months, and then take more indicators. Okay, so that's about it, and I think I have another 3 to 4 minutes. Deep.
Thank you, Dr. Abel. Thank you for the very fruitful discussion. I know it's not easy to capitalize everything in 1 hour, but you've done it very well. I think you've done that justification for the 1 hour. What we'll do now, we'll have 5 questions as of now. If anybody would like to ask a question as of now, you can mention live, you can raise a hand, and or you can put it in the chat box. So we have first question from VM. I'm not sure. Please go ahead. You have raised a hand, VM. I will just request you to introduce yourself, your organization, and go ahead with your question. Thank you. Okay, so we got a first question from Rimas. The question is, as per the standard, FPP is applicable for initially granted privileges. Is it including in the newly appointed doctors? This is a very good question, and I had a discussion with Dr. Abel on this morning as well. So, Dr. Abel, would you like to take this question?
So as I told you, FPP is always part of new privileging. When I say new privileging, the hospital can design, for example, if a doctor, as I told, I just give the cardiologist example. He has been already given privilege in interventional cardiology. He has joined newly. Okay. Now so he requests for a EP privilege, electrophysiology privilege also initially. But the hospital CNP team is not so confident about giving privilege on EP initially. Okay. So this can, what the hospital can do is they can give a metrics, and they can say 3 months we'll observe you, and based on that, okay, and the outcomes, then we can give permanent privilege for that. So the point of observation is focused in this case. And second thing is related to an existing consultant, okay, who has been doing and whose performance is not that much satisfactory. then the organization can put him in performance plan. They can give, for example, the mortality rates are very high for a particular surgery or something like that. The organization can observe him for 90 days, 120 days, 180 days, and then either decide to take off the police out of him, and then they can take a call whether to further allow him to continue with the existing privileges. So these are two things which we conferred with the surveys also. This is as per my understanding with regards to this.
Thank you, Dr. Abel. We have 1 more minute left. If any questions are there. So just an update, we have requested Dr. Abel to conduct one workshop. So he will be conducting one workshop, detailed workshop. It will be 1-day workshop on JCI 8th edition, and that will be in month of April or May. So the details will be shared with all of you. But as of now, we wanted him to give a first-hand experience. And in terms of like Dr. Abel, I just have a quick question. Any particular like takeaways in terms of IPSG that you mentioned, like, suppose it's not met. Okay, we do understand, but that doesn't undermines the importance of this. But in the scoring mechanism, now it's like met and not met. There's no partially met. So how do they rate this thing? Like, suppose they do the documentation audit, and when they are looking at the files and documentation, the completeness is not 100%. So will they make it not met, or will there still be some gray area like before?
But here it's a very challenging question what you're asking me. But again, this was not disclosed to us. Okay. So luckily we didn't get any scoring on IPSG goals. So okay. I will not be in a position to answer this question.
No problem.
Yeah.
Yeah, I know. They actually, JCI keeping this information to themselves. Actually, we asked this question during JCI workshop also. They were not very clear on that part. They did not disclose that part as of now, that what basis they will be looking at in terms of fully met and not met. Okay, we have another question.
The hospital survey book is that, for example, they don't, for example, if 10 samples are there, 8 out of 10 samples should qualify you for a met, and less than 8 samples. Okay, it will be a not. So that thing they've given in the guidebook. For example, say they're checking, say, for example, say checking for IPSG 1, 8 samples are evaluated. Okay, out of the 8 samples, 1 or 2 are not up to the mark, 8 were okay. Still, you get a met for that, not a not met.
Okay, great. Thank you so much for that answer. We have next question from Dr. Zakaria, and the question is that what are the checks to be considered for FMS 8.04?
With regard to 8.04?
Yeah, Dr. Zakaria, you want to elaborate your question if you want to speak by unmuting your mic.
Hello, good afternoon.
Good afternoon. Hi. Yes, Dr. Zakaria.
Yeah, my name is Zakri Ahmed Khan, and I'm not a doctor. I am working for Al Khan University Hospitals in Nairobi, Kenya. Okay. And we are expected to have a survey, hopefully, in the coming months. So I wanted to understand that FMS 8.04, where mechanical and engineering controls have been introduced, which are a part of PCI 10 earlier. So I wanted to understand that what are the checks that are being done on ground to verify these controls, because we've got controls on ground for isolation rooms, for other areas which are required to be pressurized and contaminant free. So what are the things which are being done in order to verify them on ground?
See, one is the HEPA filter validation. That is one of the engineering controls. Then you have the negative pressure, positive pressure rooms. Okay, noting down the values for that. Okay, just to check whether they're as per the acceptable range or not. That is one thing. And all your engineering control things will come related to information control will come under this. And your air quality. For example, having a class 5 at the plenum level and class 7 at the floor level in OTs. All these things will come into picture with regards to engineering controls.
Okay.
Just stuff it. Yeah.
Okay. And Dr. Zavia, I'm getting a lot of messages to share your contact details again. So if you can share your slide, it will be great.
Sure.
And we'll take the next question from Dikshita, and that's how do you verify the patient's identity during the teleconsultation? is there any guidelines to follow?
Teleconsultation, of course, we didn't have it in our scope. Okay, but this suggestion and this question, I'm requesting Deependra to answer this.
Okay, it's like, a challenging question, Dakshita. We, in a teleconsultation standard, basically, there are a lot of understanding in terms of patient identification, but as per some of the standards, the video recorded should also be saved. Okay, so there has to be like, video which patient is on and doctors on the other side. So by the photo identity, which is issued by a national regulatory body or by the passport, that photo identity plays a big role, but it does not undermine your two identifiers. So when you face the patient, you have to ask the same question: what is your full name? The patient has to answer. Then you ask the date of birth. Patient has to answer. And additional verification will be through the photo identity of the patient. That's a normal practice what we are following. Great. I think that's as of now the question. So thank you so much, Dr. Abel. We really appreciate your time and in-depth knowledge. I know it's very smooth journey for you. It's not easy for us, but yeah, you have done so many assessments, so you are very clear and concise about all the requirements from JCI standards. And we look forward for welcoming you for a detailed workshop. And for everyone, thank you so much for attending this workshop. It's important that you have taken out time from your work or from your off day to attend this. It's a very important thing. And please feel free to ask questions if you have any in the group as well. And we will look forward for getting answers to those questions. So thank you so much, everyone. Thank you, Dr. Abel, for a wonderful presentation.
Thank you. Thank you. Thank you. Bye.
Take care.
Thank
Bye-bye.
you.
Bye, everyone.
Thank you. Thank you.
Thank you.
Thank you.
Thank you. Thank you.